Start. Good evening, friends. Welcome back to third session of international webinar on pediatric airway problems. We have a unique theme today, that is pediatric obstructive sleep apnea, and Dr. E.V Raman, the director of pediatric airway problem services at Manipal Hospital, Bangalore, is going to moderate the session and he is going to introduce all the distinguished faculty. I welcome Dr. E.V Raman sir to this program and request him to moderate this program. Welcome, sir. Please take over.
Thank you very much, Prahlad. I think I should begin at the ending. Let's thank Prahlad for giving us this stage where this orphan specialty of pediatric otolaryngology has some visibility.
Yes,
and we've been going from subject to subject, topic to topic. The first one was, of course, on the evaluation from basics. The next one was on pediatric tracheostomy. We had a fairly good response to both these topics. And then we thought that to make the programs more popular, we'll confront those clinical problems with which all of us face sometime or the other. And this particular topic we're going to discuss today on pediatric sleep apnea is one of those. And we have this gang of 6 or gang of 4 remarkable guys participating in this. I'm talking about the sleep surgeons. They beautifully carved a wonderful niche for themselves and also propagating their skills and teaching others. And they are a model society to follow. I respect them and acknowledge what they have done for the otolaryngology fraternity, taking this specialty of sleep study, sleep surgery to higher levels. And hopefully their induction today will give us some adrenaline, and we should also start galloping like them. The first speaker today is Dr. Seemab Shaikh, and he's going to, he's a head of the sleep surgery department in Pune, and a very close friend, and has been very active as the founder of the Sleep Society, Sleep Surgery Society. I welcome him and request him to start his talk on basically the basic concepts of sleep apnea in children. We know that children are different, and I'm sure we'll be wiser at the end of his talk. We have a few questions soon after his talk, and after that, the next speaker follows. And finally, when all the three have spoken, we'll have a chat or discussion amongst each other. We've got 2 eminent panelists because I'm actually illiterate in this area. So we've got Dr. Sandeep Bansal, professor from PGI Chandigarh, one of the elitist institutions in the country, and an active member of the Sleep Society. And so is Associate Professor Dr. Sowmya from St. John's, the prestigious St. John's Medical College. And she's another passionate otolaryngologist working in this field. So we'll have the wisdom, we'll have the benefit of their wisdom as and when it is required during this program. Thank you very much for joining. Without much ado, Seemab, the stage is all yours.
You can share your screen, Seemab.
Yeah, I'll do that. This will start. Okay, perfect. Is it there?
Yeah, perfect. You can do the slideshow and you're good to go.
I need to have the first slide on. Okay, perfect.
Yeah.
So by the time Seemab organizes, I just need to tell you, the Constitution gave us the right to snore and sleep. It was a fundamental right. And these 6 or 7 people or 20, I don't know how many they are, they took away this right from us. So we are at their mercy. So please listen without sleeping.
I'm going to try and make sure that, those rights are well maintained. Thank you very much, Raman sir. Disclosures at the outset, nothing over here to disclose, and the presentation is in absolute accordance with MCI guidelines for a non-sponsored academic talk. So let me also start with a very big thank you to the people here. And like Dr. Raman said, our association goes many years back, over a decade or more, and started at a social gathering. And I can't really tell you how this man has inspired us to become very academic in our approach, right from the time when he was dealing with things as simple as maybe otitis media once upon a time. And that's how it all started. So he's been a really good inspiration for the academics that we've seen. And we all know his work in the field of pediatric airway. So thank you, Dr. Raman, get us all together. Dr. Prahlad, again, for giving us this platform, a wonderful person. And, we all know the kind of work that he does. The first time that I looked up this man after having met him And I realized that I would need a visa to get to Chitradurga. And to imagine that from that place onwards, he's got such phenomenal work, which he's got all well documented and presented, and the way that he goes ahead. A very big thank you to you, Dr. Prahlad. Srinivas is a very, very good pal of mine. Our journey has probably started just a few years up and down. We've been together all through the while. I just love the way he thinks academically, the way he approaches his subject, the way he does his work. I mean, he's a great, great person to have as the group that we have all together. It's always wonderful to work with him. The best part is I've always had to, be after Srinivas. I love to follow him when he finishes his talk and then I give my talk, because that makes it very easy for me, because I have very little then to be really sharing. This time around, I think Raman sir decided to put me in front, but he doesn't realize that whatever I don't know, I will still go ahead and say that, okay, Srinivas will deal with this after I'm done. And a very big thank you to all, of course, my experts, Sandeep and Sowmya. Sandeep's also a very good person, part of our team. And Sowmya has also been with us for a long time, and they're going to take questions for us. And for all of you who are currently affected by the pandemic and probably don't have anything better on a Sunday, please welcome and join us and listen in to what we have to say. Now, what I've been asked to talk about is something very simple. It's ENT surgeon's perspective of pediatric OSA. So I really don't have much to talk over here, because this is how a child presents to you. This is how you're going to look inside into that child, figure out where the obstruction is. You're going to do a tonsil adenoidectomy under GA, and that's it. That's the end of the story. We are done. Thank you very much for your kind attention and having listened to me at the end of this talk, because that's all there is to it. But sorry, picture abhi tak bahut baki hai mere doston. And this is where I am probably being brought in to try and give you an understanding of how all of us, like Dr. Raman said, got into OSA as a field. And we tried to figure out a lot of things about OSA. And then we went ahead further to check out pediatric OSA and realized that it's just not about tonsil and adenoids at all. So let me try and demystify a few things which are not just the tonsil and adenoids, and I'll keep it very simple as much as I can. The complications started happening when we got involved with sleep endoscopies in the pediatric age group, when the pediatric PSG started happening much more, and that's when we realized that the magnitude of the problem was very huge. And there was a lot of problems that persisted post the TNA. So with the increased use of polysomnographies and pediatric dyes, we realized that there were almost about 15 to 20% of children that were prevailing or that remained with persistent OSA symptoms at the end of the surgeries. So all this thing about how they present, how they come with witness episodes, we all know that, how they come with poor academic performance, growth failure. I think this is for every common general ENT surgeon. We all know all of this. We also know how the nasal obstruction is to be looked into the nose. We also know what's to be looked into the oropharynx. Adenoid facies is something which we don't really see much in today, but we try to figure it out with a X-ray or whatever we need to figure out the size of the adenoids, and then we go ahead and do an adenoidectomy. But a few things of importance that we need to really understand as the ENT surgeons also would be in the examination, not only just a craniofacial abnormality, because that would stare you in the face, but you will also need to look in terms of neuromuscular disorders or hypotonia, spasticities. CP will also look you into the face, but a little bit more of in-depth evaluation with neuromuscular disorders is something that we would like you to take back home, knowing that that's something to be looked into. We don't normally need any X-rays anymore now, because we have the advent of scopes, and even simple pediatric rigid scopes in your OPD will give you a lot of information about where the adenoids is and how it gets blocked. So that's not really much for us to really worry about the X-ray. So what exactly remains the role of the radiological investigations then? So you can do an X-ray, obviously, because that will give us an information of the adenoid airway, blocking the airway. The MRI is definitely not required in the pediatric age group, although I was the one who initially promoted a lot of dynamic MRIs, but not for pediatric age group, because you don't need that to diagnose unless and until it is needed in craniofacial abnormalities, where you really need more in-depth study of the entire airway of the pediatric age group. That's where sometimes a dynamic MRI can definitely come into the picture. So today's date, we will not be having any role except for probably just documentation, and only for the presence of, informing the parents accordingly what we need, explaining to them, and for craniofacial abnormalities. But when it comes to a dynamic MRI, I don't think you need that for documentation or counseling. It's only restricted to craniofacial abnormalities because, like I said just now, it's meant for assessing the airway in a much more detailed manner as you need to do. The other important thing with the pediatric age group is the pediatric PSG. Now, it's a talked about topic. There are lots of issues with this. You have logistic issues, you have availability issues, just like you have in the adults. You have a lot of these issues that we need to come to. And more importantly, you need to understand that the criteria for pediatric OSA of AHI being even 1 to 5, as mentioned here, becomes mild. Now, what is the significance here is the fact that any patient, any child who's also been operated will invariably have at least one apneic event through an hour of the night, which would put him with an AHI of 1. So it's very rare that you're ever going to get an AHI of 0. So with an AHI of 1, if the child is labeled as a mild sleep apneic, this is where the data, and this is something really important for you to understand, this is where the data of post-TAR pediatric OSA remnants gets over amplified. So any child with an AHI of 1 will still remain as a pediatric OSA, although he's been operated, and that's how probably the data gets over amplified in such situations. So we need to address this. This is something that we really need to address. So barring where the role of PSG is in children, theoretically, practically, I think we will reserve it only for those children where we need to have the neuromuscular disorders assessed, and the craniofacial abnormalities that need to be assessed, because we need to then figure out more importantly there. But more importantly, if I have a child who's presenting with a history which is not matching the clinical examination that I've done, well, that's somewhere where definitely a pediatric PSG will come in. And this, I say this, that it should be ideally done prior to touching the patient surgically. So this is where sometimes the role of pediatric PSG becomes very important, barring the logistics, barring the availability and all that. That's for, for us to keep arguing all the time. But when you're dealing with a subspecialty of a subspecialty in an age group of the pediatrics, then it really needs us to be a little bit more alert about what we are going to be doing. So when do we actually really do a PSG post tonsillectomy is a very big question. So why would you really need to do one? So it's as simple as a post-PES CT scan. If the patient is fine, you're not going to do a CT scan. If the patient is fine post-TAR, you would really not need to do one. And if at all you really needed to do one, if there was a failure, you could have prevented that failure had you done the PSG probably earlier. So post-TAR PSG, if at all, let me say this again, if at all it needs to be done, we at least need to wait for 6 months post-TAR. Do not start labeling anything as a failure post-TAR by doing a PSG immediately, especially if you have not done a PSG pre-operative, right? So this is very important for you to understand. Pulse oximetry is just something which is there in the American guidelines. We won't get into that much. And the other important factor in the pediatric OSA is either it's the PSG or the DICE. These are the two major evaluatory tools that we have even in adults, and we try to do that in children also. So it would, again, my answer would remain the same when it comes to DICE or a PSG. When do you do it? I would definitely do it if I'm finding any kind of a mismatch between the history and severity of what has been told to me, along with the findings. And of course, in patients with craniofacial abnormalities, neuromuscular disorders, if I'm going to be actually touching them surgically initially, I would really like to know that I'm not missing something way down the line in the airway. So this is somewhere where you really need to do it. As a routine, we may or may not really do it, but these two indications definitely yes. Now, whether you do a DICE or not, drastically, and my medical legal background, I have seen a lot of cases where the snoring that has been happening, or probably the sound that is there, which is thought to be snoring, or because of pediatric OSA with the tonsil and adenoids, has had something to do with the vocal cords like you just saw here. And they actually took the child up for surgery and intubation. At the time of induction, they could not intubate. There was hypoxic brain damage, etc., etc. Medico-legal issues propped up. So irrespective of whether you're doing a pre-op DICE or not, a pre-surgery DICE or not, you cannot overlook the importance of a FNLP pre-op. Definitely cannot. Which will bring us to very simple questions about when to operate, what to operate, and what kind of technology to be used to operate or not to operate, of course, is one very big question. Now, technology part, I will not really touch on much because everybody knows a very standard statement that is made world across, that it's the man behind the tool that matters. It doesn't matter what technology you use, provided you've made sure that you've got the right decision making and the right tools for you that work for you. But whether to operate or not is a decision now which is becoming very simple, because just as we talk about pediatric allergic rhinitis leading to adult asthma, we are talking about being extremely aggressive in pediatric OSA cases, because this is very important to prevent further comorbidities that come up as the child grows. And these decisions would obviously not only be made just on the basis of obstruction and the levels of obstruction, but on the quality of life issues and the failure to thrive of that particular patient, of the particular child. That would be a very, very determining factor. So once you decided to operate, the question also comes about when to operate. By when to operate, I don't mean immediately after your decision to operate, but the fact that we know that early intervention to prevent maxillofacial issues are definitely needed. But the question would come is how early is early? Now, here's a study that's come out of Mannheim University in Germany. You can go online and look up this study, which very clearly shows that the growth of the facial bones is way, way completed by the age of 5 years. It's almost up to 70%. And they have kind of given a guidance to say that, you know, you should start as ENTs to be starting to treat as early as the age of 2 years. And even the orthodontists have been advised to intervene as early as 3 years. Now, this used to be a very big issue maybe in the earlier years, because we're all worried about handling such small children. But with the advent of, say, technology, and I don't mean to, talk about any particular technology, but with the present bloodlessing technologies that are available, I think a lot of us are going down and doing them as early as even 1.5, 2 years, if actually and very much needed with failure to thrive issues. So it's very important that you operate as early as you can. And there have been various studies. You can go online, check on a lot of this meta-analysis and reviews, which have very clearly tried to identify. They've actually gone to the extent of trying to identify a threshold age, in inverted commas, whereby if you cross that threshold age, your probable neurocognitive deficits would become irreversible. So they're trying to really identify that particular threshold age. That's how important it is. And again, if you go online, this is a very famous, the CHAT study, right? Which I didn't even really know it was called the CHAT study till the time that I've been actually reading about it. But the fact is, they tried to identify a waiting group, wait and watch group, and a group which went in for earlier adenoid tonsillectomies. And very clearly, they were able to identify and state very clearly that, you know, there was a lot of improvement with early surgical treatment, both in terms of polysomnographic evidence as well as quality of life quotient evidences, although the neuropsychological testings may not have really shown something. This is a very, very interesting study for those already who do not know about it. I think you should go up and read it on the net. It's a very detailed study where they waited for about 6-7 months in some people, and they went ahead and operated some others. But they found that definitely there was a lot of pros to early intervention and early surgery. Now, what to operate? Adenoids, everybody knows. Tonsils, everybody knows. I wouldn't really go too much into the details of a coblation adenoidectomy or any other kind of adenoidectomy, except for a fact to tell our ENT audiences that, you know, there's a lot of talk that happens about the endpoint and the so-called boundaries of a complete adenoidectomy. So we need to understand that all statements made with respect to going down to the fascia and going as far laterally are absolutely acceptable and absolutely should be what one should aim for. But any statement which says that not having done that leads to an incomplete adenoidectomy or leads to increased chances of recurrence of adenoids are not really to be accepted. So I'm making that part of it in a very clear statement that, it is good to go right till the end. If you are, through with your learning curve with the coagulator, if you're able to achieve that, wonderful. It's an adenoid. It's not a cancer tissue that really needs to go everywhere. It's not a cholesteatoma where every thing needs to be out. But yes, we do want to achieve wider and wider areas for completing the adenoidectomy. A concept of tonsillotomy has also come in recently, whereby we had a lot of arguments with the pediatrician. So they talked about the immune function preservation once the tonsils are out. So what we did was there's a lot of this in the world that's coming out where only the part that is bulging out of the anterior and posterior pillars is removed and the rest of the tonsil is kept inside, thereby opening up the airway just as much as is needed, but not really removing the entire tonsils as such. Now, this obviously has no added advantage in terms of a surgeon's point of view, because if you analyze literature everywhere, barring the day one, day two, let's say benefits of low hemorrhage rate or maybe shorter operation time and probably a little bit of faster pain relief, in the long term, whether you did an intracapsular or an extracapsular, it didn't really make too much of a difference whether you had a tonsillectomy or a tonsillotomy. And this has been amply proven with a lot of literature coming out. The thing that we tend to miss out in a pediatric OSA is the turbinates and the septum, because we were brought up with the fact that, don't touch the septum before the age of 18. So I would request a lot of you all to please get on to the rhinoseptoplasty platforms of the country or of the world, and you will realize when they talk, you will see from their literature that it doesn't hold true anymore. The ossification centers are not going to be touched. They're not going to be burdened. And even today, if a septum needs to be operated, they would do it as early as 6 years, 7 years in many cases. So this is something which really they're talking about it evidence-based. None of them are talking through their hat saying that I do it, so it works. So we also need to incorporate that and understand that yes, it's just not the tonsil and adenoid when it comes to pediatric OSA. There is a lot of component with the turbinates. There's a lot of component with the septum.
Go.
There is the palate part also that needs to be looked into. So you need to have a slightly adult child who's got probably a bulky palate. You need to get him to have somnoplasty done and get that also sorted out. It's just not, again, only the upper part of the airway. At a tertiary center where I am in, just like how Dr. Raman works, we do get a lot of references at very early infancy, 10 days old kids, 15-day-old kids who have been thought to have laryngomalacia, and they're not really improving on the BiPAPs that are being used in the NICUs. And you tend to go in and you see a falling epiglottis, so you have to really go in there and cut the aryepiglottic folds, sometimes to an extent where you can also try to take a suture between the epiglottis and get onto the base of tongue. So it's not just pediatric OSA, it's just not remaining there with the tonsil adenoids. Even many a times you get references, or you may yourself find people where the epiglottis also needs to be looked into. The syndromic children are the ones that are a major concern. And you'll be surprised that till a few days back, me and Srinivas were on another webinar where I picked up this, that I wasn't really aware myself that in the pediatric age group, hypoglossal nerve stimulators are being used. Of course, this is in the Western countries. We have yet to get stimulators for the adult. So where's the question of using them in children? But what I found intriguing, and it was a very interesting point that I picked up, was the fact that they are using hypoglossal nerve stimulators in children with syndromic issues. Because we tend to look into the bony procedures and the MMAs. But the one question that I've always had to answer many a times, and I'm preempting this question and putting it up here, is the fact that in a syndromic child, if you're going to be addressing only the bony cage abnormality, what happens to the soft tissue in that child? So it is obviously, it stands to logical reasoning that unless you also remove the soft tissue, extra tissue that is there in that bony cage, just by expanding the bony cage alone may not be enough. So maybe for those who are not able to go in for a straightforward bony cage procedure, you may still have to do an adenoid tonsillectomy in those syndromic children. Of course, needless to say, with all the precautions of the consents and the guardians and etc., etc., because they are syndromic and they may have cerebral palsy also. But you need to remove the soft tissue before you can attend to the bony cage in that also. And you will see a lot of literature out there again, whether you evaluate by pre and post PSG or not, that adenotonsillectomy definitely leaves a lot of persistence behind. This is literature before we started venturing into it and trying to make protocols to tell you, which I'm trying to tell you again right now, that this is not exactly a failure of the TAR surgery, because even though they keep talking about a lot of residual disease or a lot of post-operative pediatric OSA remaining, you have to understand what is the difference between residual and recurrence. Now, I'm not going to get into much detail about this because I'm leaving Srinivas to handle this part of our talk, and then we'll come back again later on where I'll try to mention a few points. But the fact that I see something like this pre-operatively, either with a flexible scope or otherwise, and a lingual tonsil, which I have told the patients that I will probably not tackle it in stage 1 surgery, but come back again and clear it, would then not be called as residual OSA in statistics. Because I have already identified it before, I am only staging the surgical removal. I'm not doing it one time. Now, these are the cases that generally come back, and they are the ones that were labeled as residual OSA. So if you are very clear with your preoperative assessment, and if you're very clear with your preoperative understanding of the pediatric OSA, I don't see any reason why we should have an entity called as a residual OSA or a recurrent OSA. So I'm not going to get into this right now. To handle that part of so-called residual. Now, henceforth, I will be using the terminology of so-called residual OSA, because I personally do not think that it is residual or recurrence to that effect. Now, you definitely have a role of weight loss management in such children, because if they have not been tackled pre-operatively, then you're going to have to tackle them post-operatively. There are other things which Srinivas will deal with the expansion sphincter pharyngoplasty now as a part of the disease process, or sorry, improvement process. There are things where you will have to look into their downs, their CP, their thyroid issues, their obesity, because that again, if had you not looked into it earlier, or maybe you were not in a position to because the child required an earlier surgery because of quality of life issues, then in that case, this needs to be tackled post-operatively. But again, I would not like to call this as residual OSA. Same thing applies to the medical management post-operatively also. And that is the reason why we say that if you identified a child with allergic rhinitis with a pediatric OSA, and if the child is not having failure to thrive issues, it makes sense to wait for 1 or 2 months and have a complete medical management of the allergic rhinitis, whether it mometasone, whether it is budesonide, get that thing settled and then go in for a surgery, because post-surgery, this lack of treating the allergic rhinitis would be classified or rather put down as a residual OSA. And these are there in the American Academy guidelines also. The only last thing probably that is important in a child OSA, in a pediatric OSA, is the use of CPAP, because although we can put it there in guidelines, it is not so easy to do that. And I would always recommend, again, this is where the role of the flexible scopy pre-surgery or pre-CPAP comes in. Because if you see a child with a collapsing epiglottis like this and you give a CPAP, you're going to suffocate him or her more than actually help. So for practical purposes in my practice, what I would recommend is that only PAP therapy is to be used only for those not willing for surgery, those with a severe comorbidity issue with a very low to high, risk to benefit ratio being very low. In that case, one must look into a PAP therapy. But believe me, PAP therapy is not so easy to initiate in a child, and you have to have a specific separate department that deals with PAP therapy, where you have therapists not only from the point of view of the machine, but also the behavioral therapist that will help the child to adapt. Because you must understand that majority of this PAP does get used in children with comorbidities or with children with craniofacial abnormalities. and they need extra attention. So it's not for an ENT surgeon to just straight away go and say, go ahead and use CPAP. It requires a lot of working on into. It requires a lot of reassessment, readjustment, because you have put the patient on PAP therapy only because the patient under
Seema,
into
there was
this,
some
but
audio.
a few take-home messages would be. There was some audio
Yeah.
issue.
Can you repeat the slide? There was some audio issue. Can you repeat the slide? That this thing, previous one.
Repeat this slide. Issue, PAP therapy issue, right?
Next one. Previous one. Previous one. Yeah. Yeah, I think this is the one.
No, so the PAP therapy over here was okay. So I'll just say it again just for a minute. So what I'm trying to exhausted all the other options that are there. So you just can't push the child onto a PAP therapy. It requires a very dedicated separate department that needs to work on the PAP therapy. And this department would not only have people with the PAP machines, but it will need behavioral psychologists, it would need pediatricians, it would need a lot of people there who will try to get the child adjusted to the PAP therapy, make sure he's using it well, making sure that the compliance is much better, at least more than 2-3 hours every night, and just not throw them away to the PAP therapy. So PAP therapy in children is probably one of the only things which is extremely important in a so-called residual or a recurrent OSA, because you have probably not have anything else to offer them. So these algorithms would come much later, but primarily, although it being a clinical diagnosis, I would like to make it very, very clear to everybody, please do not shy away from doing a simple flexible scopy for a child of pediatric OSA prior to surgery or prior to planning your treatment, because in these situations is where the incidence, which is so-called high, which has to be kept in mind, will drastically come down, and we would not have an entity called as a residual OSA or a post-operative recurrent OSA, except for situations like this, which I'm not dealing with in this talk, because you can have a nasal obstruction contributing to pediatric OSA, which could be because of dental issues, which need to be tackled much later on. I'm sure Srinivas will touch on that. There are other issues there which you need to understand, that you have to have myofunctional therapy, you have to have myofunctional appliances in kids, again, which I'm sure Srinivas will touch on. But leaving you with this one last little thing to understand, that we've been treating pediatric OSA as very casually. It is no longer to be treated as casually as it was, as just a tonsil and adenoid. And even today, a tonsil and adenoid should not be reserved just as an outpatient surgery, because whether you do, so if you see this slide, whether you do a preoperative PSG or you don't, if you have a suspicion of severe OSA, or if you have a confirmed severe OSA on PSG, these patients definitely need admission for more than a day. So those ones which you have only mild to moderate and are more than 3 years without comorbidities can go as outpatients. But those with comorbidities and less than 3 years, do not keep them on outpatient. And those suspected of severe OSA, do not keep them as outpatient. And this, I say, applies whether you do a preoperative PSG or you don't, because this group remains the same. Less than 3 years with comorbidities, or ones with severe OSA, whether on PSG or on clinical evaluation, please do not use them or treat them as outpatients. And please make sure that pediatric OSA gets its due importance, and not just something that, oh, it's a tonsil and adenoid and we'll go ahead and remove it and we are done. So with that, I would just hand it over to the organizers with one simple thing, that please don't base your decisions on the advice of those who don't have to deal with the results. And that is the reason why we as a group are doing our level best to get out standard operating protocols, because these are the ones you need to follow. You don't need to follow your peer pressure or your peer group that says, oh, we don't need to do this, or why do we need pediatric dyes? Why do we need pediatric PSG? That's where the problems come in. So please do try to follow the protocols that will be put up. Thank you very much. I'm going to stop sharing screen so the organizers can take over.
Thank you very much, Seemab. That was excellent. You passed in some ways, you also failed in some ways.
I
You
lost
passed
the time a bit.
No, you passed because you stuck to time. But you failed because you
Okay.
gave much more information than we ever imagined. It was not sufficient, it was beyond sufficient. Thank you for sharing all this with us. We have a very well-informed audience. Rakesh, we have Shashidhar, we've got Ajoy, we've got Izzy, we've got Mary, Suja, Naina, Dr. Biligi, Dr. Manoj Shan. All these people are there, apart from the wonderful questions that are coming, so we don't want to waste any time. So I think we'll go on to the next talk, but in case my esteemed panelists, one or two comments, Sowmya and Dr. Bansal, you can just give your short comments now, and then we'll have a discussion later. Sowmya?
You need to unmute her. I think she's still muted. Sandeep, are you able to unmute yourself?
Let me see. Did they mute themselves?
No. Okay. So if you made me
One
co-host,
minute. I'll unmute Dr. Sowmya.
Yeah.
Then where is Dr. Sandeep? Disappear.
okay,
Yeah.
I've asked him to unmute. If you
Yeah, Dr. Sandeep.
Yeah.
Dr. Sowmya is unmuted.
I have been able to unmute myself.
Yeah. Okay.
Dr. Seemab, it was a very nice talk. Very well, you have covered most of the topics. There are just a few things that I would like to add. One is pediatric OSA is a very tricky concept. It is not easy to diagnose like in adults because children normally have a lot of sleep variability. It is natural for them to have sleep variability. And also the challenge is that even a single apnea, like Dr. Seemab mentioned, is considered as a mild OSA. According to the American Academy of Pediatrics, we have to evaluate every child with snoring. So that should be something of a part of a protocol that all ENT doctors have to do when a child comes to see them. So it should be part of our examination protocol that we should be forthcoming to ask them questions. And a simple pediatric sleep questionnaire, which is a 21 question questionnaire by Ronald Sherwin, that can be also kept on our table and given to the parent. So that is easy for them. So with that, we will get a fair idea what is the degree of the OSA. And like Dr. Seemab said, it is difficult to get the correct equipment to do a polysomnogram in the hospital setting. So we had, through an ICMR project, we had got the specific probes. So when that cannot be done, because it is difficult for every practitioner to have that, the simplest thing is to maintain a pulse oximeter at home. The parent can measure the oxygen saturation of the child and then come up with a diary, overnight saturation, whether it is falling below 90%, how often it falls, and if the child is very restless during sleep. So these are some rough indicators that the child is suffering. And allergic rhinitis is also a big component which can aggravate it. So probably by tackling allergic rhinitis, we can do well to avoid the sleep apneas.
Thank you, Sowmya. Sandeep, quick comment because we need more time later for discussion also.
Yes. I think excellent presentation as usual, Seemab. A very important point which Seemab has pointed out is about obesity, the BMI. So it is so important for the adults also. And majority of the children are obese these days, if not morbidly obese, at least overweight and obese. And that has a lot of problems of the residual OSA in children. And secondly, a very important point I think is to scope the child if you have a flexible scope, because a lot of these children have lingual hypertrophy. So just doing a tonsil adenoid resection might not be enough. And if there is lingual hypertrophy, we need to remove those lingual tonsils also. And that is a very important and a very common factor which leads to residual OSA. That's what I've seen in my practice, that the lingual tonsils are a very important factor which we overlook usually and just get away with tonsil adenoids, and that's it.
Thank you. Thank you so much for your comments. Without much ado, we need to go ahead. And I have the honor and privilege of inviting one of our team members, Dr. Gnanam. She is the head of the Pediatric Emergency Services in Manipal Hospital. And she's going to talk to us about the pediatrician's perspective of sleep apnea. And she's the jewel in the crown in our organization. We have probably, I don't know, I love to blow my own trumpet, but it's a totally interdisciplinary group we've been running for the last 19 years. We have from one end people like Gnanam. We also have pediatric pulmonologists, which many of you have. We have a pediatric gastroenterologist who's joined the crew, SLP, etc. And we all evaluate all these children. Almost 80–90% of our work is done free of cost. So that is the reason we've been able to build this interdisciplinary group. And the contribution made by people like Gnanam for the outcome, final outcome, is not measurable at all. Without much ado, Dr. Gnanam, please.
Yes, sir. Thank you so much, especially Dr. Raman, for inviting me to this, elite group. And I also want to thank the ever enthusiastic Deepa for dragging me into this. Actually, I was literally kind of upset with her because I'm a foreign body here and I'm not sure what is the right way to put things across. But still, I will try my best. And I was requesting Dr. Raman to not give me just OSA because we've been seeing a lot of neurological related sleep issues a lot in children. So then he told me that you could talk on sleep disordered breathing. And so I had a lot of reading to do, a lot of catch up to do, and then put all my thoughts and videos together. So I hope I'll be doing a good job. Mysterious sleep, and this one famed researcher, sleep scientist, has said that if sleep doesn't serve as an absolutely vital function, it is the greatest mistake evolution ever made. And breathing, which serves yet another absolutely vital function, can unfortunately be disordered during sleep. So two very, very indispensable functions of the body are here taken for a toss. And this image, which is there on the left side, is Joe the Fat Boy from Charles Dickens, the posthumous Pickwickian child. So the Pickwickian syndrome was named after this. And so it dates back to the early 19th century, actually. So with this, we just start off with sleep disordered breathing. So what happens during normal sleep? What is the effect of normal sleep on breathing? So we are physicians. We like to talk a lot about physiology. So under normal conditions, what actually happens when a normal person sleeps is there is a diminished drive to the center to breathe normally itself. And this leads to a slightly reduced lung volume and the chemoresponsiveness. So we have the central and peripheral chemoreceptors which respond to hypoxia and hypercapnia, and that responsiveness is also a tad diminished during normal sleep. The skeletal muscle tone is slightly diminished during REM-related sleep, and the upper airway resistance may slightly be more during normal sleep. So this is the new normal with sleep in normal individuals. And so sleep disordered breathing means there is a disruption of this new normal respiratory pattern and ventilation during sleep. And now I have taken the liberty to classify this because I couldn't find any other terminology quoting all the other non-obstructive etiologies. So I have called it predominantly obstructive and predominantly non-obstructive. I hope I'm not crossing my limits here. Obstructive, I'll probably touch base very briefly. All of you are aware it is a syndrome of upper airway dysfunction during sleep, which is characterized by snoring and or an increased respiratory effort because of an increase in the airway resistance and pharyngeal collapsibility. You are the expert in the classification of this. I'm not going to go into the detail of the simple snoring, upper airway resistance, obstructive hyperventilation, sleep apnea, etc. I'll skip this. But if there are postgraduates and if there are people who are learning here, so the physiology here is kind of really, really interesting because there is a intricate interplay of very vulnerable anatomy here. So there is a little bit of upper airway narrowing, either because of a hypertrophy, adenotonsillar, maybe midfacial hypoplasia, maybe intraluminal growth, maybe micrognathia, anatomical facial dysmorphism. So there is a little bit of an upper airway narrowing because of an anatomical problem. In addition to that, there is also, like I told you, the physiologic mechanisms which happen normally, that is a bit exaggerated. And so there is ventilator instability related to this exaggeration. Also, there is a reduced or absent muscle control. The dilator muscle, which is supposed to keep the airway patent, even that is missing. So an intricate interplay of all these factors cause a bit of obstructive bar, predominantly non-obstructive sleep apnea, as you may call it. So there has to be a balance of forces. Now, these forces, what we are talking about, are the dilating forces and the collapsing forces. So the upper airway experts, you know, it is a rigid tube with a supraglottic pharynx, which is considerably collapsible. So the dilating forces of the upper airway are predominantly the muscle tone and a positive intraluminal pressure, whereas the collapsing forces are a tissue mass, maybe an intralesional or intraluminal or an extraluminal mass, and a negative intraluminal pressure that causes a collapse. So a pressure which is outside this collapsible segment, when that is greater than or exceeds the pressure inside the collapsible segment, this is called the peak crit, as all of you know. It is during this time that the airway collapse happens. This is really important for us intensivists and pediatricians because, like Dr. Seemab was talking about, the CPAP and NIV and HFNC. So we do a lot of this in children, and for many of Dr. Raman's patients, we have tried this. And so here is when we find a remarkable difference by putting these children onto HFNC and NIV. I will be touching base very, very briefly on that in the end of the discussion. So we need to achieve a balance of forces. Now, this is a no-brainer. So this is just to start off with a normal snoring kind of adenoid hypertrophy, as you can see there, happening in a child. But it's a no-brainer, like I said. So there is an adenoid hypertrophy, the child was taken up for surgery, and things happen. So for Dr. Raman's patients, we actually, even if it is a straightforward adenoid hypertrophy or adenoid tonsillar hypertrophy, he kind of sends the patient to our upper airway clinic, where I am also part of, and we do an overnight sleep study in the emergency room. And I'll be also talking about what we do in the emergency room for him. In addition to just looking at certain numbers, we also do an echo to look at the pulmonary pressures for looking at, complications related to a chronic upper airway obstruction. So we've got a slightly modified sleep study, which we do here, which I'll touch base a bit later. This was an interesting patient of Dr. Raman also. I just stop talking as you listen to this. I want you to watch the pattern of breathing here from where we obtain a lot of information. So if you see his pattern, it is paradoxical. The chest is moving in with inspiration and out with expiration, suggesting a very severe obstruction. And look at the SATs are fine, but look at that plethysmograph, look at the SpO2 waveform, it's going up and down, again indicating a very severe obstruction. This child, the history was very interesting. 3 months of noisy breathing, which happens only during sleep. When he's awake, he's perfectly fine. And he walked into the ER. Dr. Raman had referred, and he said, just have a look. It's okay, fine. So he just walked into the ER, no noise, absolutely nothing. And then so we did a sleep study in the ICU, and this is what we noticed. The PCO2, so we also do a blood gas in certain select patients. The PCO2 turned out to be about 55 odd, and bicarb was high, indicating a chronic obstruction. This child turned out to have a laryngeal chondroma and then was operated by Dr. Raman and team, and he's doing extremely well. So this again is an intraluminal obstruction, and because of the collapsing force, like I told you, there is a mass inside, and the negative pressure during the breathing is causing a lot of obstruction here, and that is causing a paradoxical breathing. So this is absolutely not adenoid tonsillar hypertrophy. It is obviously not anything to do with laryngomalacia, cleft, etc. So he did pretty well also. Now, why are we worried about obstructive sleep related or sleep disordered breathing? So all of you know there can be neurocognitive impairment. We concentrate a lot on the cardiovascular component of this. I have seen a lot of children with pulmonary hypertension, and in fact, Dr. Deepa is writing a paper on laryngomalacia. We are kind of trying to grade laryngomalacia and looking at pulmonary hypertension for children who have have severe laryngomalacia. So that is one pickup which we do very early. Apart from that, it is said that there is a lot of low-grade systemic inflammation happening, daytime somnolence, a lot of metabolic abnormalities. So the consequences are aplenty. And so obviously, we need to recognize these symptoms early and try and tackle them. Now, I am talking I'm just going to concentrate a bit more on the predominantly non-obstructive sleep disordered breathing. So this lady here, so she's a mythological nymph, apparently. Undine was her name. Actually, it is spelled as Undine, U-N-D-I-N-E. So she kind of cursed her beloved who betrayed her and said that you will forget to breathe when you sleep. So the predominantly non-obstructive is what we as pediatricians see quite a bit. Almost 1 or 2 in a month is what we see. Here I have kind of classified them, again taken the liberty, pardon me, as central hypoventilation syndromes, neuromuscular causes, restrictive thoracic, especially chest wall disorders, chronic lung disease, and the physiologic periodic breathing which we see in the newborn. Now, the central hypoventilation is definitely not obstructive. And this is one of it is Ondine's curse, which I spoke to you about, that is congenital. We have also a case record of 5 children presenting with this late onset hypoventilation. It's also called as rapid onset obesity with hypothalamic dysfunction, hypoventilation and autonomic dysregulation, ROHHAD it's called. We've had 5 patients, I mean, you won't believe it, but Dr. Raman was involved with at least 4 of them, I think. All of them, onset was after 3-4 years. All of them were becoming obese rapidly. One of them had a neural crest tumor also. All of them underwent tracheostomy. They were on home ventilation. 2 of them were lost for follow-up, and 3 of them, unfortunately, we lost them. But this is a late onset hypoventilation, and there is some mutation which has been detected in a particular gene called FOX2B gene. So that is a central hypoventilation. We have other structural, metabolic, and genetic causes for breathing, sleep disordered breathing also. For example, a child with mitochondrial disease can have a sleep disordered breathing. A child with Rett syndrome, children with Prader-Willi, all of these can have sleep disordered breathing, which is there during wakefulness also, but when they are sleeping, it is much more pronounced because of the factors that I had mentioned earlier. So this is a very interesting child. I want you to notice closely. You can see his tummy move almost like a high frequency oscillator. It's like literally fibrillating the abdomen. Notice the abdomen. And this is during sleep. That's what he's doing during sleep. So he was diagnosed as laryngomalacia in the probably immediate newborn period, or maybe 2-3 months of age, and was tracheostomized considering that. And they attempted decannulating him, I think twice before he was referred to Dr. Raman. And Dr. Raman, he calls me a third umpire. So he said, I want your input here. And he sent the child to me. We did a sleep study. So this was during sleep, and this was during wakefulness. Absolutely fine child, breathing normally, extremely awake, active. So he was absolutely fine. And that was the monitor, which is showing, I'll try to freeze it there, which is showing a PCO2. This is recording 52. So we have obviously there's a tracheostomy. So we've attached a end-tidal carbon dioxide monitor here. The lowest was 52. This is when he was awake. When he was sleeping, it was close to 65, 70, and the blood gas had a value of almost 90 with a pH of 7.3 something compensated. So he is a kind of a hypoventilation at sleep. So obviously we did not decannulate him. He was told to continue proper NIV during sleep at home, or rather a kind of a IPAP, EPAP kind of support with a ventilator at home. Parents were doctors, so they were able to follow this up diligently. And we have not heard back from them in the last 3 months. We yet to see how he's doing. Coming to the second etiology, this is a partially obstructive and non-obstructive. It is a mix of both. Neuromuscular causes, it can be a spinal cord involvement, it can be SMA kind of lesions, it can be a acquired Guillain-Barré kind of syndromes where the peripheral neurons are involved, or myasthenia gravis and myopathies. But here what is important is that they may actually be fine during sleep whenever muscle exertion is minimal, because all the time their respiratory muscles, the diaphragm, the intercostals are kind of weak. So when they are exerting less, which is during sleep, they actually do well. But when they have any kind of an infection, or when the basal metabolic rate increases, that is when they have a problem. So what happens in this neuromuscular and restrictive thoracic issues is that there is a diaphragm weakness, there is weakness of the accessory muscles, there is also upper airway muscle weakness, there is atelectasis of the lung, and obviously the chemoresponsiveness to PO2 and PCO2 is also diminished. So all of this is there. So when they are exerting their muscles less during sleep, they may actually do fine. But when they have an infection, like this particular child with a myopathy came to us, see how he's breathing. He came with an aspiration, and I want you to notice the gasping kind of breath that he's having when he's awake. So he's a mitochondrial myopathy child, and he had an infection when he came to us. And when he was awake, he was trying to do these sigh breaths. It's almost like gasping, if you noticed. Those sigh breaths to kind of, saturations were fine, probably 90% on room air, and we started oxygen. He's so conscious. I mean, imagine a normal child who's breathing like this, he'll be completely obtunded. Because it's a chronic illness, he's so conscious and is trying to breathe like that. But I unfortunately did not take a video when he slept, because by then we had started him on NIV already. So when he slept, there was no effort at all. So we tried NIV, it didn't work, and then he had to be intubated, obviously. So this is a myopathy where I'm saying the contrary may happen. When the child is well, they do well with sleep. And when they have an illness, they do well when they are awake, and they do badly with sleep. So this is a kind of stuff which we have noticed over a period of several years. Non-obstructive miscellaneous will be a chronic lung disease. So during sleep, normally, I told you the new normal itself, the drive is diminished. So the minute ventilation is diminished. So there may be some hypoxemia and hypercarbia, which may be worse during sleep in chronic lung disease than when they are awake. And all these chronic lung disease patients, when they go home on a ventilator or a HFNC, when they go home on, the night requirement is much more than the daytime requirement. Physiologic periodic breathing in neonates, this is normal. It is just related to the immaturity of the CNS. And so they kind of have a waxing, waning breathing. They breathe well for some time. They have pauses of apnea. They breathe again. But after 2 months or 3 months maximum, they get better. So this is not actually a sleep breathing disorder. It is more of physiological. So we need to have a multidisciplinary approach. So what we need to do in all these is that obviously recognize early, and that's what Dr. Raman and team are doing. They're recognizing really early, identify the type of sleep disordered breathing. Is it predominantly obstructive, anatomical, or is it kind of anything to do with neuromuscular and center? Plan diagnostic modalities and decide if it is intervenable. And most important is to educate family on warning signs and symptoms and train them accordingly. So we have training varying from, like Dr. Sowmya was saying, giving them a pulse oximeter home, and we have training as far as doing a CPR and bagging in the tracheostomy. So that's what we do for our children. So early recognition, there is no substitute for an astute history and examination. So this kind of, it was actually, the mnemonic was bears, but I didn't like it, so I changed it to snare. So S is for find out what is the kind of sleep disordered breathing pattern the child has, and ask the parent to take some videos and post it to you or show it to you when they come and see you with the chest completely exposed. Also ask them to record any kind of noisy breathing, N, which is observed during sleep, and record the number of awakenings during night because of discomfort, because of PCO2 retention, because of whatever reasons. How many times is the child getting aroused? Also look at the regularity and the duration of sleep and excessive daytime sleepiness. This is in addition to taking the symptom history, etc. Snare is another history which we would strongly advocate. Examination, apart from the regular examination, look for facial dysmorphism, Mallampati classification if needed. Look for airway reflexes. So we specifically look at drooling, the gag reflex, the cough reflex. to look for palatopharyngeal incoordination. We specifically look for hypotonia and obviously the respiratory pattern. So this will kind of help us to decide on whether it is an anatomical related problem or it is a functional problem related to neuromuscular. So that is our sleep study monitoring chart, which we call it the modified sleep study chart. And you may not be able to see the details, but what is basically there is we do a continuous, so we admit the child in the evening time to either the ER or the ICU, where we do a continuous saturation monitoring, apart from a continuous heart rate monitoring. We have the nasal end-tidal CO2. So we record the carbon dioxide levels also. We have video recordings of the respiratory pattern 3 or 4 times, sometimes 2 times when it's normal and 2 times when it's abnormal. And in select cases, we do a venous blood gas just before the child wakes up if the nasal end-tidal carbon dioxide is kind of on the higher side. And these children also get an echo done depending on the grade of severity to look for pulmonary hypertension. So that is the monitor that I'm talking about. Apart from the heart rate, saturation, and the respiration, this is the EtCO2, or rather the nasal end-tidal CO2 that I was talking about. So a higher value means that he's not ventilating well and there is a problem. And so we'll end up doing a blood gas to look at what is happening. But most important, what I feel is that polysomnography, like somebody had mentioned, it is technically not feasible in children. More than 5-6 years, they may cooperate with for a EMG and EOG and all, but below that it's really, really difficult, and you obviously can't sedate them also to get a PSG done. So I mean, all this is already there, but we just put everything together and we're doing this modified sleep study, overnight observation. But what I feel is most important is a doctor who is present. So in the ER and the ICU, I have trained doctors to kind of look at the child, keep looking at the child and observing the child and give his own interpretation, then show us the video the next day. So the next day, Dr. Raman and myself have a look at the videos and get the doctor's interpretation, look at these readings, and then take a call on what has to be done, etc. So do all of them need intervention? Dr. Seemab had wonderfully mentioned about the difficulty with NIV HFNC. Yeah, obstructive with a clear etiology. I'm not touching on that. All of you are experts for surgical intervention. For a predominantly non-obstructive, I have started off with watchful expectancy and ended with masterly inactivity. I mean, watchful expectancy is where nothing much can be done, but you just train the family, and probably every month or 2 months, you go on a video consult and keep making sure that everything is well with the child. SATs are fine, feeding is fine, growth is fine, child is not going into an infection. That is watchful expectancy. We have tried high flow nasal cannula kind of therapy in many children with varied degrees of success, predominantly successful. NIV with a mask, like Dr. Seemab said, is extremely difficult in small children, but if they have been tracheostomized, it is way too easy. So we have at least about 15 kids the last 20 years who've gone home on NIV with a tracheostomy. Intubation and tracheostomy ventilation, obviously, for the really sick ones. Masterly inactivity is for the, I don't want to say, but the neurodegenerative kind of category where really nothing much can be done. I really wouldn't advocate being all brave and going and exploring them. So we need to take a call on mitochondrial disorders, or a Lay's disease, or a myopathy, SMA, those kind of situations where nothing much can be done. We kind of talk to the family and give them a plan of action on, if it comes to ventilation, what to do. So this is the range of interventions that can be done. A word on HFNC. So that is the high flow nasal cannula, a small machine. I'm sure many of you must have seen it. It has an inbuilt compressor. It has a source where you can humidify by pouring saline or water, and oxygen, which is connected here. So here, what the HFNC, it's just a prongs in small babies as well as in older children. We set what is called a distending pressure. We set the flow, and that culminates into a pressure. And so, like I told you, balance of forces. So by giving the distension pressure, it overcomes the collapsing pressure and keeps the airway a bit open. So we have kind of tried it as an interim in certain children. For example, this laryngomalacia child, where you can see there's so much of retractions. As a stopgap, I'm not saying it's a treatment of choice, but as a stopgap till we decide, till the family decides. Suppose they say, I don't want surgery, then what to do? So as a stopgap, we have tried in many patients, HFNC. In fact, rental machines are available where a couple of families have taken it on rent and tried. We've had a child with hypothyroidism congenital with a TSH level of almost 700. She was in HFNC for almost 6 months, and currently she's doing well. So HFNC is remarkable. It is much, much easier to handle than an NIV, and parents can be trained, no major complications. So it does bridge the gap and balance the forces. NIV is tough, like Dr. Seemab said. It is quite tough because the mask fit needs to be really, really appropriate in a child. So if we don't get the appropriate fit and the child doesn't cooperate, it becomes a disaster. So we obviously can't do it in a small child, but older children, we've had children with thoracic deformities, kyphoscoliosis beyond 10 years, 11 years, and those with tracheostomy, we sent them home on NIV. Like I said, almost 15 patients in the last 15 years we've had. So I think that's it. Hippocrates said it's far more important to know what person the disease has than what disease the person has. So suppose you know this child has a neuromuscular, then you know what the disease is rather than what disease the person has. So I hope I've done justice to what Dr. Raman has told me. Free to take questions. Thank you.
Thank you so much, Gnanam, for that. You know, there are supposed to be, Donald Rumsfeld was asked where Osama bin Laden was hiding. So his answer was this. He said that there were three kinds of knowns. The things that you know, the things you know you do not know, and the things you do not know you do not know. And you told us about the last category in abundant measure. Thank you very much. Wonderful talk. No insult to our panelists, but there is one question which I wanted to answer just to get the audience involved. She says, ma'am, this is from Dharmishta Kaku. Ma'am, in case of non-obstructive causes, do you do ETCO2 during sleep study? If it's chronic high in NM disorders, neuromuscular disorders, is it possible to wean these children off the tracheostomy and the CPAP?
We do. So we're talking about two categories of patients, one who is tracheostomized and one who is not. So for a non-tracheostomized neuromuscular, we can do a nasal entitle. So there's a small cannula which gets attached to the monitor and we can see the carbon dioxide levels. But those who have a tracheostomy, it's straightforward. You just attach the entitle there like I showed you and we can see the values. So, like I said, a neuromuscular you may not be able to wean the child because the child has a neuromuscular. It is, I mean, I think it may be depending on the etiology. So if you're talking about cerebral palsy, if you're talking about a myopathy, if you're talking about mitochondrial, things are not going to get better. And I'm not sure the element of surgical option that you have. Maybe if you try the adenoid tonsil removal and things are better, then maybe we can consider weaning. But otherwise for neuromuscular, weaning is generally not an option. I hope I've answered your question.
Yeah, thank you. If Dr. Gnanam had not been in my team, I would have probably done 500 laryngomalacia surgeries, but I ended up doing 50, I think. She's our third umpire. You need somebody to put brakes on it, but then it's very satisfying when you have another person to help you out with these cases because you don't want a case where you've done everything and the outcome is bad. So if you don't mind, Sowmya and Dr. Sandeep, we'll go to Dr. Srinivas' talk. We are still in time, but I want a lot of discussion after the talks are over. Srinivas, here you go.
Yes.
Dr. Srinivas doesn't require any introduction. He's another founding member of the sleep study. He practices in Hyderabad, a very good friend of mine. And I always invite only friends to talk, so it's okay. So in case he takes more time, I'm going to ask him to shorten it a little bit. And yeah, go ahead, Srinivas.
Can you see my screen?
Yeah.
All right. Good evening, everybody. Thank you, Dr. Gnanam and Seemab for a fantastic talk. I mean, really always learn from these webinars. Thank you, Dr. Prahlad and Dr. E.V Raman for the fantastic platform that you all have made. And hello, everybody. I see a lot of familiar faces, and I'm going to talk to you about what we call recalcitrant pediatric OSA. The correct terminology is persistent pediatric OSA. So I have a small disclaimer. I'm going to show a lot of pictures, and all the pictures and videos have been consented for from these patients who they have been taken. Now, this talk definitely deserves and owes I owe a lot to CG. The entire sleep apnea fraternity in the world owes a lot to CG, as he's very sweetly called. He's the one who's basically coined these terms, and that is the reason why we are all here and talking about sleep apnea. And he's basically published first in the 70s about pediatric sleep apnea, and that's how everything else came into force. And I would like to dedicate this talk to CG, who's left us exactly a year ago. So, the gold standard in the management of obstructive sleep apnea, according to the American Academy of Sleep Medicine, the American Pediatric Sleep Society, and the American Academy of Otolaryngology, and the Indian Association of Surgeons for Sleep Apnea, is adenoidectomy with or without tonsillectomy. If you look at the images, this is the first image on the right side is an image of the tonsil that we don't see very often. This is an image of a scope, and we're looking at it from the nasopharynx, and we're looking at grade 4 tonsils, and that's how much the airway is really blocked in the oropharynx. And this is a picture of intracorneal adenoid, and most of us see this picture. And whenever we see intracorneal adenoids and we see huge tonsils like this where there is no space, and we do an adenoidectomy and a tonsillectomy in these children, and we see and we feel very happy. You know, it's very gratifying to see huge tonsils and adenoids dissolving, and we know at the end of the procedure you're looking at huge spaces, and at the end of the procedure you see so much space. But if you really look at the success rates of doing adenoid tonsillectomy for every child who presents with obstructive sleep apnea or obstructive sleep-related breathing disorders, I really like the way Dr. Gnanam's basically differentiated it, non-obstructive and obstructive. So if you are looking at an obstructive sleep-related breathing disorder, and if you were to do adenoid tonsillectomy for every patient, the success rate is all over the place. You know, the success rate can vary between 27 and 80%. And we're looking at a cure rate of about 40%. So why is there a huge difference of 27 to 80%? Here is a video of a child for whom TNA has been done 6 months ago. And if you can basically see this child, it's a video taken by the parent, and you can very clearly see that there is increased work of breathing. Pay attention to how much she's struggling to get air into her lungs. And you can also see she's basically had a little bit of an arousal. Also pay attention to the mouth breathing and try to pay attention to the dentition out there. Here is another watchpad study of an 8-year-old who's had RDI of 34 pre-op and post-op RDI 56. Well, if it were to be an adult, it would have been a gorilla moment for me, wherein I would be thumping my chest and said, wow, I've had a great result. But this is a pediatric patient, and 5.6 is not acceptable. Here is another teenager for whom this is a level 2 study. AHI pre-op was 45, and I've done an adenoid tonsillectomy. Post-op AHI is 4.9. Again, not enough. So there are significant number of patients with persistent obstructive sleep apnea following adenoid tonsillectomy. And as you know, the saying that kids are not little adults. So if it's an adult and you didn't do an amazing job in surgery when you're doing surgical management of adult obstructive sleep apnea, you can always fall back on a CPAP. But if you put a CPAP for a child, they are very suboptimally treated. Now, why is that? Because of multiple problems, and I think this is not a platform to talk about that. So let's go further. So if you talk about numbers, we're talking about 15 to 37% of your patients having persistent symptoms in spite of tonsil adenoid. And all of us have these portion of patients with the parents coming back and saying, parents like Meera, as I've shown you a video of showing us that the child is still not sleeping well, the neurocognitive functions have not improved, the behavior is still not changed, and so on and so forth. So if you were to have some kind of a tool which is not subjective and objective, wouldn't it be helpful? So David Ghosal, who's a giant in the field of obstructive sleep apnea, pediatric obstructive sleep apnea, he has multiple presentations. He's come out with a very commonly used tool that we use as an inflammatory marker, highly sensitive CRP, which can be used as an objective sort of a measure to look for if these children require further evaluation post-TNA or no. So from tomorrow, you can use these tools. I use it definitely in my practice, and I have seen that if there is some kind of inflammation going on, highly sensitive CRP can help you to sort of move in the direction of further evaluation. So these are kids of mine for whom I've done adenoid tonsillectomies. Each one of them are special because they're just not patients with simple adenoid tonsillectomy. These one child of this is a Prader-Willi syndrome. If Dr. Shashi is there, he would who would remember the last child, Alex, who's a premature child. He's had obstructive sleep apnea with subglottic stenosis, and then further we've repaired it. He's developed tracheomalacia, for whom he's done a patch tracheoplasty, and this child is still with us with sleep apnea. So here is another child. This is a child for whom adenoid tonsillectomy was done. Can you believe it? I mean, anybody who would listen to this child, this is a child in natural sleep, who's just sleeping in the pre-op area, would know that this child is having some kind of a laryngeal problem. So it is kids like this, and what the parents come out with is just tip of the iceberg. Below what's going on is multiple effects on cardiovascular system, hypertension, ventricular remodeling, neurocognitive problems. And recently there's been a paper that basically said that if there is sleep apnea, there is significant cortical atrophy that is going to happen. So if you look at all those in one way, the influence of sleep-related breathing disorder in on facial growth is another direction altogether. So mouth breathing can lead to septal deviation if you lower the tongue position, causing constricted maxillary arch, and then there is an extended head posture causing lowered maxillary portion. And this is a child you can see post adenoid tonsillectomy. Somebody has an upper jaw like this with a complete loss of tongue-palate coupling, which should hold the tongue in the oral cavity instead of where it would lie in the oropharynx, causing persistent sleep apnea. Now, this kind of facial features would ultimately change this child from a sleep-related breathing disorder to an awake disordered breathing, and opening a cascade of events which basically make the child more and more sick. Now, can we predict these potential failures? Who are the kids with the red flags going around? Now, if you are seeing a child with adenoid tonsillar hypertrophy causing or to be causing obstructive sleep apnea symptoms, who's syndromic, who's having craniofacial anomalies, who's obese, and who's having allergies, these are the kids your antenna should go up. These are the kids who probably will not do so well with a simple adenoid tonsillectomy. These are the kids with persistent obstructive sleep apnea. So if you take obese kids for that matter, if you were to do a simple adenoid tonsillectomy for these kids, you know your success rate? Your success rate is a measly 10 to 25%, compared to a non-obese child whose success rate would be 70 to 80%. If you were to do a simple adenoid tonsillectomy in a Down's child, the success rate is between 30 to 60%. Why? Because again, Down syndrome kids are uniquely poised. They have two problems working against you. One is reduced muscle tone. Two is these kids are slightly obese. So neuromuscular kids, craniofacial kids, kids with sickle cell disease who basically have their lymphoid tissues, that means their adenoids and tonsils compensating for their loss of spleen, kids with mucopolysaccharidosis, and kids who basically have high AHIs and kids who are in their teens and late teens. These are your high-risk kids. So when you have suspecting obstructive sleep apnea and they are into this kind of categories, please remember you are not going to get a very good success rate if you do adenoid tonsillectomy alone. Now, also there is literature that basically says that if you were to do a sleep study in kids and you find out that these kids are having a lot of nocturnal hypercapnia, as Dr. Gnanam beautifully showed, and hypoxemia on the pre-op PSG, again, you are not going to have a very successful adenoid tonsillectomy. So, persistent sleep apnea, dealing with persistent sleep apnea is a challenge because in a child, and all of you would agree, you're not dealing with just the child. You're dealing with the parent and the respective parent. So at any given scenario, you are dealing with at least 6 to 8 individuals at the same time. It's going to be very challenging and it's very emotional for all of them. So it's very important to bring in a strategy called shared decision making. This is a term that I've learned from the people from Cincinnati Children's, and this is something that they use a lot. You need to understand that persistent sleep apnea is no longer an isolated adenoid tonsillar obstruction. It is a multi-level disease. And it's very difficult to obtain a comprehensive upper airway exam in a child. Even when you talk about a simple thing like flexible laryngopharyngoscopy, the grandmother would jump in and come onto your face. Of course, I'm talking about the pre-COVID era, and say, is it really necessary? You know, so you're basically dealing with 6 very emotional people. So you need to be very careful, but you still need to do what needs to be done. So the question arises, should we put these children, all of them, through a very vigorous treatment protocol, or can we try conservative management? Yes, you can. If you have an obese child and if just make them lose weight, the OSA was successfully treated in 80% of these individuals. And if you remember the high risk slide that I was talking about, the success rate is only 10 to 25%. Whereas if you make them just lose weight, its success rate is 80%. So if you are dealing with an obese child, please try to make them lose weight. What about the combination of montelukast and INCS, intranasal corticosteroids? A lot of studies have been made, have been done and published, but a lot of literature is there on budesonide, fluticasone, and mometasone. But what I would like to emphasize at this point is please don't withdraw the treatment before you give it a fair chance to work. Give the treatment for at least 3 to 4 months before you withdraw. But please remember, this is only for mild patients, not for severe patients. What about PAP? It has been shown that in unmotivated children, the mean usage time is 2 hours. And that is why you cannot fall back on CPAP as a treatment strategy for you. And this is very useful, especially for these kids with obstructive hypopneas and nocturnal alveolar hypoventilation, which has been beautifully discussed by Dr. Gnanam. Now, a lot of importance is now for myofunctional re-education, and I will be happy to share with you all, but now I don't have time to talk about myofunctional therapy. What you are doing here is you are re-educating the muscles of the tongue and also the muscles of the oral cavity, the buccinators and all these things, which have completely this disuse atrophy because of chronic mouth breathing. So all my children of adenoid tonsillectomy are put through these myofunctional therapy sessions. And if there is time, I will definitely share this video with you. Now, what is the way forward for the moderate and severe cases? Mild cases, yes, you're going to try conservative management. So you basically have to get them to do polysomnography. You need to get them to do a flexible laryngopharyngoscopy at least, and drug-induced sleep endoscopy or a CNEMR. Each one of these brings their own advantages to the table. Now, all of them give very sort of objective analysis to the whole problem. I would definitely urge all of you, like Dr. Sowmya was saying, there are a whole bunch of questionnaires that can be used that will bring in the parents' confidence level and increase the parents' confidence level. There is the Modified Epworth Sleep Scale. There is the OSA 18 questionnaire. So if you give these questionnaires to these parents, they also feel sort of very connected to the whole treatment, and helps in what we now call shared decision making, so that this is not easy. Dealing with persistent sleep apnea is not easy. So we would want the parent also to be equally involved in the decision making for these patients. So there is again a lot of published literature that basically said that both DICE and CNEMR, when used to direct surgery for pediatric patients, the results are much better than if you don't have something to show. So these are like torchlights that show you directions in a dark room, because a PSG would tell you how bad physiologically the problem is. Your questionnaires will tell you how bad the parent is perceiving this problem. But for a surgeon, for you to know how to proceed, you need some kind of an anatomical identification of the problem, and that is where exactly DICE and CNEMR would fit your prescription. So this is a picture of a child with persistent OSA, wherein the adenoid is basically regrown. I have to apologize. My exposure to CNEMR is very limited. My colleague, Dr. Vijay Krishnan from Chennai, he's very active in this. So if time permits, probably we can have his discussion also later. But I absolutely love DICE in persistent pediatric sleep apnea. And a lot of literature is now coming. This is a patient of post-TNA who's a teenager, basically. Again, see, his adenoid is completely regrown. The patient has undergone a very conservative tonsillectomy 3 years ago, and the entire tonsils are back again. They've completely grown back. And this is a patient with significant persistent obstructive sleep apnea. Again, I would like you to understand this child's mouth breathing, complete loss of what we now call loss of coupling, tongue-palate coupling, resulting in the tongue base falling backwards. So the only difference between adult and pediatric is that you will induce with sevoflurane and immediately cut it. Once the IV line is put, then you basically stop it. You normally use dexmedetomidine and use ketamine at dosages of 1.1 to 2 mics per kg per hour. And ketamine, you can keep giving it as boluses, and you get beautiful pictures of the behavior of the upper airway. And scoring, like the adult, we don't have a proper scoring system, but in pediatric, this is what we use. We have to bring in the adenoid, the velum, the lateral pharyngeal wall. The pictures are very self-explanatory, the tongue base, and not to forget the supraglottis. So unlike in adult where you're only talking about velum, oropharynx, tongue base, and epiglottis, here you're talking about adenoids, lateral pharyngeal wall, and supraglottis as well. So here's another beautiful paper from Sally Short and Stacy Eastman from Cincinnati Children's talking about outcomes of drug-induced sleep endoscopy directed surgery, which again tells us how important this particular investigation is. I would like to bring in at this point what we also call a state-dependent laryngomalacia, or also called as occult laryngomalacia, was first coined by Amin and Isaacson from 1997, refers to a child having normal breathing when awake, but suddenly becomes stridulous with increased work of breathing during sleep. And this kind of laryngomalacia can be beautifully brought about during drug-induced sleep endoscopy. This is not a neonate or an infant. This is a 7-year-old child with occult laryngomalacia. So supraglottoplasties are something which you can use. This is not a 7-year-old with supraglottoplasty. This is an infant again. Just want to show you in this slide how beautifully the results are. If you were to diagnose the supraglottis to be the culprit of persistent obstructive sleep apnea, the results are phenomenal. You have great results coming from AHIs ranging from 60 to almost 20. This still doesn't mean that you're out of the woods, but it basically tells us that doing supraglottoplasty would give you very good results. And you can use any tool you want. I'm using coblation. You can use simple scissors. You can use true cutting instruments, which gives good results. Like again, Seemab said, it's not about the tool. How you apply it, it is about the fool behind the tool. So coming to surgical management, if you find in DICE that there is residual OSA because of obstruction at the level of the velum, gone are those days we would do very aggressive UPPP. We do what is called as an expansion sphincter pharyngoplasty, which is beautifully adopted for the pediatric age group, wherein very conservatively, I'm not using any tool which is a hot dissection technique, using scissors, and wherein we steel the posterior pillar, make a tunnel, and basically relocate the palatopharyngeus muscle. To put it diagrammatically, this is the elevated palatopharyngeus muscle. Maintain its attachments to the posterior pillar, relocate them, and you get good results from expansion sphincter pharyngoplasty. Pediatric lingual tonsil hypertrophy is graded. This is one of the commonest causes. Almost 80% of residual OSA is because of pediatric lingual tonsil hypertrophy. You grade it based on the amount of lingual tonsil that is filling your valvular from grades 1 to 4. And lingual tonsillectomy is very gratifying. Again, you can use a lot of, you can use laser, you can use diathermy, but I think if you want to do a brilliant lingual tonsillectomy, nothing like Coblator. I don't own any shares with Smith & Nephew, but I think this is a fantastic tool to do lingual tonsillectomy. But if you observe, I'm almost working under water. So this sort of pulls the tissue down. The collateral damage is very less. And also when you use it, try to make it a non-touch technique. As you can see, let the plasma work for you and melt away the lingual tonsils. But what about kids like this? These are children of mine who come with this kind of jaws. I'm sorry to say they look more canine-ish, like a wolf, than anything else. Look at the persistent nasal obstructions these kids would have. So if you do an amazing drug-induced sleep endoscopy or do an amazing adenoid tonsillectomy or an expansion sphincter pharyngoplasty, if they still have a persistent retromaxillary obstruction, you're still going to have a failure at your hands. And again, literature says that the prevalence of malocclusion in children with OSA is about a staggering 89.9% compared to control groups. So you cannot ignore this fact that these children need to be treated. Even if you do a septoplasty or a turbinectomy or a turbinoplasty and empty the entire nose, these children are not going to get better. And these are the kids in whom you need to do rapid maxillary expansion. And I can tell you that me and our pediodontist, Dr. Gayatri, we work together and you get brilliant results, brilliant results. This is pre-expansion. This is post-expansion. The roof of the mouth is nothing but the floor of the nose. And these kids, just by doing this expansion after a brilliant TNA, with this, they do very well. So to put the management in a nutshell, weight loss is pivotal and primary. You can use CPAP, oral appliance, intranasal corticosteroid, all these are there. So you need to apply these when based on your tools, both objective and subjective tools. And here I've put in some kind of an algorithm. This is something that I use. I basically first differentiate whether am I dealing with, if I'm dealing with a persistent OSA, I'm not talking about normal OSA, I'm talking about persistent OSA. Am I dealing with a non-syndromic or am I dealing with a syndromic patient? If I'm dealing with a syndromic patient, I definitely get a PSG done. I would definitely get a level 1 PSG done. I would do a DICE on a CineMR and basically try and see whether which is the treatment plan that would best suited for that particular patient. If it's a non-syndromic patient, I would look at it in this way. Is it high risk or low risk? And why is there persistent OSA in this child? If there is high risk, I would, based on my drug-induced sleep endoscopy, I would do a multi-level surgery or a skeletal procedure. If it is a low risk, I would consider conservative management. And if my conservative management fails at the end of 3 months, I would do a targeted surgery. So, dear colleagues, adenoid tonsillectomy is still successful and first line of management for sleep-related breathing disorders. A subset of pediatric patients will still continue to have OSA after adenoid tonsillectomy. Drug-induced sleep endoscopy can help identify the anatomical causes for residual obstruction and guide your surgical treatment. I would like to end my talk with this beautiful saying from Ralph Waldo Emerson: to know even one life has breathed easier because you have lived. This is what to have succeeded. And this is to all the airway surgeons, whether they deal with sleep apnea or larynx or trachea, or to people like Dr. Gnanam who take care of these kind of patients. This is kudos to all of you. Thank you very much.
Thank you so much, Srinivas. I mean, it was an excellent talk. Really enjoyed talking to you. And all these talks have been so illuminating today. So I will just request our panelist, Dr. Sandeep, to give his comments, and then we'll go to the questions. Sandeep, are you unmuted, Prahlad?
No, I think Sandeep needs to unmute himself.
Okay, wait. Let me try that. Yes.
No,
Yeah, he is unmuted.
Yes, Sandeep, go ahead. Give your comments.
Yeah, I couldn't unmute myself, so that
Yeah,
was
okay,
late.
done.
Okay, excellent talk as usual. You know, the two best speakers we have today in the panel, Seemab and Kishore boss. I think Dr. Kishore has covered all the aspects about recalcitrant or residual OSA in pediatrics. I still feel that more important things are one is talking about taking care of the weight reduction. The pictures which boss you showed, all of them were overweight, if not obese. So, more and more kids are getting obese these days. So that's a very important thing. In spite of doing a very good T&R, we are not getting optimum results. And secondly is the lingual hypertrophy. You also mentioned that is the most common cause of residual OSA. So I would still feel that if we are suspecting or if we are clinically feeling that there's a severe OSA, because we are not subjecting all the patients to a PSG, so it's a good idea to at least do a FLP. And if we see lingual hypertrophied lingual tonsils, it's a good idea to do at one sitting rather than to go in again, because already the child is under anesthesia, and it's a small procedure as such. I am not sure how many patients do actually require a expansion or a relocation. Maybe Kishore can, he has shown a few videos. We can talk about that in detail. But Dr. Susan from Delhi, in St. Stephens, she is very regularly doing a simple relocation pharyngoplasty at the same sitting as the tonsil adenoid resection. Like she's doing in a lot of patients, like at the first sitting itself. So maybe that's a good idea if we talk about that residual OSA is so common in these children. And as far as the skeletal deformities are concerned, of course, our dental colleagues, maxillofacial colleagues can help us. And the jaw, the expansion is can be taken care of them. Another thing I would like to point out is these days, I feel that this is my observation in my practice, that bottle-fed children are more prone to all these problems, these dental, deformities, and thus leading to OSA. Or maybe those you are using, soothers. The children who was using soothers or bottle-fed in their childhood for a long time, rather than breastfed children. So that's another thing as a preventive measure, which we can think and which we can educate our mothers to take care of. That should not be, the child should not be bottle fed as a preventive cure for OSA, rather than ultimately leading up to a dental treatment or a surgery for those patients.
Thank you for your comments. We have Dr. Deepak Mehta, professor and head of Aerodigestive Center in Texas Children's Hospital, who's joined us. Prahlad, just unmute him. Meanwhile, I'll ask a question. There's a question to be answered. If you can unmute Deepak's mic, it'll be good. The question from the audience is Sri Mandir Kumar to everyone. Suppose the child is having noisy breathing due to hypertrophied adenoids, and tonsils, along with gross deviated septum. How do you proceed and counsel the patient as a result? May have, okay, that's Seemab, I think covered it, but Seemab, can you just answer this?
Yeah, so it's a very one-off situation where you will have such a deviated septum and the child. So obviously that child is going to have failure to thrive issues, depending on the age. Now, to correct a septum would probably take a little bit more time, and to err on the side of being late is much better than to touch the septum later. You must definitely go ahead and correct the tonsil and adenoids, having properly counseled the parents and the child what to expect, and then make sure that you will address that septum at a later date. Give it about a month, 2 months for the child to settle down, because you obviously cannot do all three in one shot. So which would be the more pressing one, or which would be the more easier one to do? Doing a nasal surgery, continuing to have a nasopharyngeal and oropharyngeal block would be more dangerous. So I would go in reverse fashion. I would do the tonsil and adenoids with the proper counseling, and then address the septum at a later date.
Next question is also for you from Santosh Kulkarni. What about adenoidectomy in a cleft palate patient, operated stroke non-operated?
So again, would depend on what exactly you would really need to be doing that adenoidectomy for. And obviously you're going to have to be a little bit more cautious in those patients when you do the adenoidectomy without vision. Barring that, I don't see any reason for a contraindication to do an adenoidectomy in a operated / non-operated cleft.
The next question for everyone is, what is the youngest age at which intranasal corticosteroids can be given?
I think all of us agree now it's about 2 years. You can start off with 2 years and above. Mometazone initially, and then you can still, in fact, I think recently they have also, FDA has approved fluticasone also for children above 3 years of age.
Yes.
Is Dr. Deepak Mehta unmuted? Deepak, are you? Prahlad, can you just unmute Dr. Deepak Mehta?
Can I? Oh, okay. Sorry.
Prahlad?
Let me find him. If I can find him, I'll try and unmute him.
Yeah, meanwhile, let me see whether there are a lot of compliments here. Excellent presentations from Dr. Ezi. Informative session. Ekambar Reddy all presented with excellent sessions, beautiful sessions.
I have unmuted Dr. Deepak Mehta. Thank you very much, Ezi, for being there. I also, while searching for Dr. Mehta, found Dr. Anil Sapaya. Wonderful to have him here.
Hey. Good evening, everyone. Sorry I joined in late. I heard Srinivas Kishore's talk. Really enjoyed it, actually. He made a lot of good points. I think the thing about sometimes what happens is we go on to, because we are used to looking at the pharynx, we miss the oral cavity. So the point he made about keeping an eye on the dentition and making sure we don't miss that. Same thing with the nasal cavity, not missing that is very important, because you might do whatever, and if you still have problems, you have not satisfied the family, not made any better for the child. So I think it's very important to have a complete thing. The other point I would make is, for the beginners who are starting to do, it's important to start to do DICE on a regular basis. There's a lot of times you learn as you adds another 2 minutes to the procedure. But if you start doing DICE for not even just the residual sleep apnea, but your sleep apnea, which is not your usual. So someone who has small tonsils, but has sleep apnea, go and assess them, because sometimes you learn things like you might find out that they have tongue-based collapse, or they might have laryngomalacia. So it's a good idea to start using DICE as a tool for your assessment for all kinds of pediatric sleep apnea. The obvious big tonsils, adenoids, it's a no-brainer. In a normal, healthy kid, go ahead and take your tonsils out. But anyone who is, say, syndromic, younger age group, all those things, start doing DICE on them. And the point which, again, Srinivas made about the tongue base, whenever you're working on the tongue base, actually coblation is a very good tool, just like what Srinivas said. It works really well. One of the things I do for exposure is use a 30-degree rigid endoscope. So you suspend like a tonsil, but keep your tonsil blade a little bit towards the circumvallate papillae, and then use a 30-degree endoscope. That will show you the whole area so nicely. And then when you use a coblator, you can actually do a better job than actually, sometimes some people use the laryngoscope to suspend. This gives you a better view and gives you.
Deepak, can you see your video?
And then
your video, can you switch on?
Okay. Video of a tongue base. It might take me a few minutes to get on that. I'm not sure. Maybe next time.
Your video.
Yeah. So I'll have to go and find. Let me see. While I'll try to find it and get on it.
No problem.
You guys talk, okay?
The reason I wanted his video to be on was Deepak has been a great supporter of upgrading our skills in the pediatric airway, and his contribution is cannot be expressed in words. So I thought the younger people should know who's making these wise statements.
I think he didn't understand what we meant. So I'm asking you to start.
You want a video of a surgery.
Visual video. There.
No, no.
Dr. Deepak, we want to see you.
We want to see you.
Okay, yeah.
Sorry, yeah, good. Thanks, Deepak, for joining in. I know you joined late because of some wrong communication on my part. So we'll, any more questions? Where is Dr. Gnanam? Is there anything that you want to tell us which you thought you missed in your call or reiterate? Is Gnanam unmuted? Deepak, Dr. Gnanam is a pediatric intensivist. You've seen her. She's part of our airway clinic.
Yeah.
We wanted to bring it focus that we need to people from other specialties to help us decipher these difficult patients. And she gave a wonderful talk. She's probably not around, is it? Can you unmute her?
I'm unmuted.
Your video? Yeah. Can we get Dr. Gnanam on the?
She's on.
She's gone. Okay.
No, she's on.
On. I like to see her when she talks. Gnanam, can you tell them about the airway clinic that we're doing? I mean, the interdisciplinary one, because in case somebody else wants to, do a similar thing.
Yeah, that was Dr. Raman's idea. So we have a airway clinic with their team and the emergency room and sometimes the ICU, where we do a lot of modified sleep study for them. Like I told you, what we monitor, the nasal end-tidal CO2 is something which we constantly have. Video recordings, which we constantly have. We do echoes to look at the pulmonary pressures. Dr. Raman, even for laryngomalacia patients and even, the simple adenoid tonsillectomy hypertrophy, sometimes when he's not very sure whether he needs to, operate them or not, they go through an elaborate sleep study, and then we take a call on, he takes a call on whether the child needs to be operated or not. So laryngomalacia has been doing really well. Deepa will be able to address on the number of cases that they have done based on this particular upper airway clinic that we are running together. So it's a really interesting area. Sometimes in the ER, I probably have seen more airway cases than the other emergencies, thanks to Dr. Raman. So yeah, it's really nice.
Thank you for your comments, Gnanam. Can Seemab speak a point? Yeah, Seemab.
I just wanted to get those two things across. So if I can just try and, get a comprehensive view of what I said and what Srinivas said. Right?
Yeah.
If you give me a minute, I'll try to...
Seemab, before you share your screen, I would just like to go on record and thank Dr. Sowmya. Initially, we never used to have end-tidal CO2s for our sleep studies in Hyderabad. So I used to send patients to St. John's, to Bangalore, to do their sleep study, pediatric sleep studies. And if you remember, actually, she's helped me a lot in that. Now, fortunately, we have procured that here. Otherwise, patients used to go all the way from Hyderabad to Bangalore to get that, because transcutaneous CO2 or end-tidals, without that, there is no sleep study in a pediatric age group. I think the whole purpose is defeated, and I would like to thank Dr. Sowmya for that.
Seemab, can we get to Sowmya first and then come to you? You don't mind? Sowmya, just please.
Yeah, so I think this was one of the first projects that we did in St. John's. It was funded by the Indian Council of Medical Research. So that's how we were able to get that expensive pediatric PSG mission. And we did 100 children completely free of cost. And like Srinivas said, he also referred some, so it added to our numbers. And one interesting thing that we found was that obesity was not necessary. In the West, obesity means, almost all the children have OSA. But here we found that in India, we get a lot of poor patients also to our hospitals. And those who had BMIs of just 15 had OSA, severe OSA. So that was a revelation. And the second thing is, we realized that big tonsils does not mean big OSA. In the sense, big tonsils does not mean severe OSA. So please do PSG properly, and it is important to incorporate the REM stage of sleep, because the REM stage is when maximum variations in sleep architecture is there. Another small case I would like to mention is that a child had come, the parent said the child has got a lot of daytime sleepiness, and when we did an X-ray, we saw huge adenoids. not huge, it was like mild adenoids, but then we were quite confused why the child is having so much of OSA. When we did the PSG, we noticed that the child had sleep paralysis. And actually what the child was having was narcolepsy. So this is an extrapolation of what Dr. Gnanam said, that it was a neuromuscular disease. By trying to do all surgical interventions on a neuromuscular disease, we might have worsened the disease. So the PSG is very important. It will give us a direction to what sort it is, what sort of condition is contributing to the OSA. So based on that, we have to do the treatment. And also this, it's important for us to know that OSA is a chronic low-grade systemic inflammation. And every child usually who comes to us, we get the cholesterol levels done. We also get the HbA1c of the child done. And if required, we refer to an endocrinologist because it is seen very commonly that there is insulin resistance. These are the few points I wanted to add. Thank you. Thanks, Srinivas.
Thank you, Sowmya. And that's why Sowmya never used to say hello to me when she met me for many years. All patients were coming from Hyderabad. Okay.
Dr. Eileen from Manipal and Dr. Raman has really helped me. Dr. Eileen, in fact, from Manipal was the one who actually coded our sleep studies. So thanks a lot to you, sir. I highly appreciate it.
I take all the compliments. Eileen is part of our gang. I love to shine in borrowed glory. Seemab, you've got exactly 5 minutes to tell us what to do. We want to put us on the straight road, how to manage. Go ahead, Seemab.
I will not even take those 5 minutes, sir. I'm going to try and give it to you very comprehensive.
Sure.
So this is my talk and Srinivas's talk combined. Let me start with what Srinivas said. He has a persistent OSA patient for whom he will do a pediatric PSG. He will do a pediatric DICE or / MRI and then go ahead and then tackle it accordingly, right? What I say in the beginning is that where do we need to do a pediatric DICE and where do we need to do a pediatric PSG? So if you do that in the first stage, there is no question of us having an entity called as a persistent or a residual OSA. That's my basic point. So that's the reason why I say, and I say this very strongly to myself, leave aside any patient that may be referred to me for a residual OSA. My own patient, if I do not evaluate in this particular manner that we've decided, that is criminal for me, because now having understood pediatric OSA, there is no question of us having residual OSA later on if you have pre-operatively done all this right in the beginning. So what you're doing post-operatively for a residual OSA is pediatric DICE, which you should ideally be doing pre-operatively. What you want to do post-operatively is a pediatric PSG, which ideally you should be doing pre-operatively. A scopy, if at all needed post-operatively, you should be doing pre-operatively. And you will not have an entity called as residual OSA. Or you will not have an entity called as a persistent OSA because you will be tackling it stage-wise. And that's how you've got to get the algorithm right. So the treatment of obesity would start earlier. The treatment of allergic rhinitis would start pre-operatively. Now, the only time when you may have to first do a tonsil adenoid before doing all of this is if you are faced with a child who is having failure to thrive issues and who needs a little bit of symptomatic improvement. So in those cases, I would say that a tonsil adenoid at an early stage would be justifiable. If not, it does not matter if we delay the tonsil adenoid by a couple of weeks or a couple of months to go ahead and treat the allergic rhinitis, to go ahead and get the pediatric PSG done and the DICE done. So personally to me, I do not wish to ever have to tackle a persistent OSA or a residual OSA because there should be no entity called that. Right? So if I can show those algorithms, I will just share the screen when you talk.
Do that quickly.
One point, residual recalcitrant OSA is an entity. It is a well-known entity and not all children will improve because this is a chronic disease over the years with increased interleukin-6, tumor necrosis factor, alpha and leptin, which has already caused damage. So complete reversal is still...
No, I agree. I'm referring, Sowmya, only to the obstructive part. So
Okay.
this is what I kind of hand out to people. It's a very rough way of looking at it. You do a clinical history exam, do a flexible scopy. If your findings correlate, you do not necessarily need to do a DICE and PSG. If they don't correlate, you will do that, right? I've kept this box in between because this is where it is but understood that you will be treating nasal allergies, polyps, URTIs along the way, because there is no hurry to do a tonsil adenoid. Now, if you go by this chart, whatever you do, whether you do a DICE or PSG preoperatively or not, your first plan will still always remain a tonsil adenoid. The only difference would be that in a scopy, if you find any other obstructions, then post this TNA, you will go ahead and then treat that as a part of a residual OSA in either an obese child or a non-obese child, where you will obviously look for these other factors. It's as simple as that I can make it, because if you follow this kind of a situation, then I don't see any reason why. I'm talking about obstructive. We are not discussing the non-obstructive pediatric OSA. So as a ENT surgeon, I should never have an obstructive residual pediatric OSA in my practice.
Very true. We must aim for that. And basically what you've said is look before you leap. Don't put the cart before the horse. Look for all these things. Counsel the patient is what probably Seemab is trying to tell us. Thank you so much, Seemab. That was really, really important. I'm glad that we gave you a few minutes to share your thoughts with us. We have a person in the wings, that is Dr. Thiru, who's just going to talk about a case he had. You see, after learning all this, how do people manage and what are the problems they face? So this is real life scenario. Thiru, are you around? Can you
Yeah.
quickly? Yeah. Thiru is a pioneer pediatric airway surgeon from Chennai, very enthusiastic, and he's going to take this area much further. He is the chief guy in the Children's Trust Hospital in Chennai, and an active surgeon. I'll leave it to him to present this case so that everything gets revised now with all the experts sitting here. That's the idea. Please, people in the audience, my esteemed friends, whoever wants to say something, we'll keep the house open.
Shall I?
Yeah, go ahead. Start.
Yeah. Thank you, Dr. Raman. So we had this child, 5-year-old child, came to the hospital with severe OSA. So, the child was not sleeping for almost like 2 days, because if the child goes into sleep, immediately she goes in for apnea. So the parents had to make her awake all the time. So almost like 2 days they did that before the child reaching to our hospital. So then we put her on CPAP, but nothing helps. So finally we decided to do a tracheostomy for the child. So this is the child. You can see the child had surgery for congenital temporomandibular joint fixation earlier, and then you can see there is a severe retrognathia, and the mouth opening is very minimal. And finally, we were able to intubate the child with the help of fiber optic endoscopy. And then I did tracheostomy, and also the same sitting we did distraction osteogenesis by the facial-maxillary surgeon, both sides. So finally, once the everything is all right, the distraction is fine, and the child was almost like about to be extubated, then the child failed extubation. So, and I did the scopy, and I found out there is a lingual tonsil. So we had to do a lingual tonsillectomy. But the lingual tonsils are more on the sides, but the posterior flapping of the epiglottis was there. So I thought maybe I can just do the midline just scarring, so that the epiglottis will be pulled back again. So unlike the midline glossectomy, what usually being done for OSA. So post lingual tonsillectomy, you can see the area is very fine now. The valvular region and the posterior of the tongue, and the tongue and the epiglottis is nicely rigidified, and it is not falling posteriorly now. And when I go down inside, you can see both the vocal cords are fine. mobile, and then subglottis and everything is fine, even tracheostoma and the superior part of the stoma, suprastomal region, everything is fine. So, but still we are not able to extubate the child. So then I did the scopy. For my surprise, there was a huge adenoid enlargement after the lingual tonsillectomy, maybe because of the Walder rings. So earlier there was no adenoid enlargement, but after lingual tonsillectomy, I found this adenoid was very huge. So then I had to do adenoidectomy for the baby, and then the story doesn't end there, because we have nicely improved the mandible, but what happens to the maxilla? So here, I had to get the help of the orthodontist. Incidentally, my wife is an orthodontist, so she came to my help. At last we had to come back to home for the help. So she did rapid maxillary expansion for the child, and ultimately we were able to extubate the child. And this is my last slide. So incidentally, yesterday I got a child, a 10 months old child came to me with a severe stridor, progressive stridor, with voice change also. So almost like 10 days child was on stridor. Before that, child was absolutely normal. So just for the audience to take a call, can you guess anything? Any guesses? So this is what was there. I did the scope yesterday, and I could see this.
Foreign body, fishbone.
So when I took the patient for scopy, I told the parents, I don't know anything at all. I don't have even a guess. So I'm just taking the patient to the theater. And, my anesthetist, who is very experienced, he said immediately, it looks like a foreign body. And then I refuted him, saying the child is having voice change and this is a progressive stridor for 10 days. How can it be a foreign body? But he was right. So ultimately there was a foreign body. It is almost like a keel sitting in between the vocal cords, and it is there because of the surrounding edema. It is a progressive stridor, and because it is in between, there was a voice change, and it is there for almost like 10 days. Now, luckily, we could manage to remove it. This is a piece of wrap from the biscuit packet or something like that. Okay, thank you very much for the opportunity. That's all from my side.
Thank you so much. This is exactly what I wanted. I want people from, experienced people from the audience also, who are, I know, doing remarkable work, to come out with one open house case where we can go through the whole thing and see what actually happens. This is a shop floor medicine. When you're faced with the patient, what to do, despite all the things that you learn in your theory. So you brought it out very well. Thank you so much, Thiru. But you also taught us two more things. That is, one is we need to have a 360-degree vision. You can't just say, because everything shouldn't, looks like a nail when you have a hammer in your hand kind of a thing. So you need to have a 360 degree. And then things could evolve. In some of our LTR patients where we have done at the age of say 2.5, this adenoids and tonsils come up a little later. And sometimes when we see that we cannot decannulate them or they have some problems, one look there and you can sort that out. That is one part. But more important than that, what I have learned from Thiru is that you must marry very wisely. And he's done it. Congratulations, Thiru, on this. I don't know how many years you've been married. You took a very good decision.
Yeah, more than 20.
Okay. Dr. Mary is a very experienced professor from CMC now in Pondicherry. She is also here in the audience. Can somebody unmute her? Prahlad, can you unmute her? While I look at the questions, there are lots of compliments for all the experts who have participated today. We are overwhelmed with your praise. Is Mary unmuted?
Mary, is it? Yeah, Mary Kurian. Yes.
Yes, okay. Yes. Thank you very much. I won't repeat saying wonderful. Yes, I hope you can hear me.
Please
Yeah,
Can
yeah.
you hear me?
Show your video also. I'd like to see whom I'm speaking to.
Oh,
We can't see you.
okay. Okay. Thank you very much for all the speakers and the panelists. Wonderful. And you know, when you hear the topic, one will wonder what more, what else. Such a wonderful feast to the eyes and ears and mind. So just two, three concerns to Dr. Seemab, Dr. Shaikh. You know, my concern always is, when do you think one's adenoidectomy is success? Is it an anatomical success or clinical success? Because it's always a problem, like you said, even after removing the whole adenoids, one does have the symptoms. So do we need to really completely remove? Because adenoids do have a function in your immunological build-up. That is number one. So I don't know whether there is an answer to it. That is then 1, 2, 3. I'll just comment, and then to Dr. Gnanam. I think your idea of a modified sleep lab is a wonderful thing. You know, polysomnography and sleep lab for a child is and many centers do not have it. And reading it, the younger the child is, the more younger ones who have obstructive symptoms, it is not easily feasible. So to have a sleep lab like yours, modified with all this, I think it's something which others should take home and think about it. And somebody did about the case study, just 1 or 2 words about the case study you spoke about. You know, somebody did ask what was the CHAT study, that is the childhood Adenoid Tonsillectomy Hypertrophy. That was a study among children, which was 5 to 9, while the CATE was a similar RCT for children 2 to 4 years. If you read at the conclusion of the authors, their conclusion was based not on their primary question. In fact, the primary question was 2 scores better or lesser than the original OAHI in score. So that study didn't answer. So the question, they said probably yes. And their inclusion criteria was also a polysomnography for a child less than 2 to 4. And in the same introduction, they do say there is controversy between that and the quality of life 18 score. So I think, but they did mention probably yes for moderates they should do, but they did there are 2 or 3 statements in their conclusion. Probably we need more studies to say. And it is just a food for thought. When we read an article, it's good to critically appraise it also. So wonderfully, really, they tried to answer the question. However, the question for the primary question, the modified Cohen didn't show a difference. If you look at the table, I just wanted to tell that it is a good exercise to appraise an article. And it's good to, probably based on the article, you can always do another article addressing the issues that may have been showed an answer towards a positive, to answer a positive, yet not so clear. That's all. 2, 3 things I want. Thank you very much for all the time.
Thank you so much for your comments. Yeah. Go ahead, Seemab.
Those points are well taken with regard to the study. That's why I just mentioned the study and just a bit of it. To answer your question, which you already answered for me by saying that we really don't have an answer to that.
Correct.
It's a fact. But the things that I've always been saying when I ever get into this kind of a debate where they talk about the endpoints of the adenoidectomy is exactly this. Our aim for an adenoidectomy is to clear the airway. It is not to remove every cotyledon of the adenoid. That's not what is the aim of the surgery. The aim of the surgery is to remove and open up the airway as much as you can. And if I was to take this one step further, to all the senior teachers of mine and even me in the earlier years, when we did a blind curettage adenoidectomy, how many actually recurred? And even those that recurred, were they clinically that symptomatic that they required a revision surgery? So that itself answers the questions as to the end point of an adenoidectomy. You really don't have to get that aggressive. You should definitely try to be, no doubt, but not get that aggressive.
No, but you still can answer, you know, doing an endoscopy and a quality of life, question 18. It's a very useful, somebody can do as a thesis itself.
It's done, ma'am. There's lots of data on OSA 18. There's lots of data on FOSQ.
I know.
There is data on a modified, so there is also called as I'm Sleepy questionnaire, one for the parent,
Yes,
one for the
I know.
child. So to answer ma'am's question, ma'am, I think the concept of complete adenoidectomy basically came in because we are nowadays seeing more and more children with obstructive sleep apnea at very early age. The ages at which we're doing adenoidectomies now or forced to do adenoidectomies are 1 year, 1.5, 2 years of age. Unfortunately, because, so now what happens, ma'am? Even if you remove the adenoid and if you don't remove the adenoid completely, there will be a natural growth of these adenoid tissues back to where they were. So if you, the more you remove, the earlier the time that the child is going to present to you back with symptoms. So I think that is somewhere you'll have to balance, you have to do a balancing act as to whether you have to do that, accept those consequences of doing just a very complete adenoidectomy. And also in children with coexisting allergies, you know that these lymphoid tissues tend to grow back very fast. So that is where I think that whole sort of confusion comes in.
I agree with you. It's multifactorial.
Yes, yes.
So fortunately, we still have a little time. Any comments from Dr. Suja or Dr. Ezi? We can unmute them and they can say their
I think Dr. Sandeep wants to make a comment, sir.
Oh, please, Dr. Sandeep. Yeah, you have the right. Yeah, Dr. Sandeep.
I would just like to take from there what and talking about what Seemab was talking about our teachers, and that we were doing curettage method previously, and there were no recurrence or relapse or whatever. I would beg to differ a bit. Like I'm not sure whether those patients those children were really followed up. So without following up a child, we cannot, we are just assuming that there was no recurrence.
Correct.
And it is very important, I think so, to do a complete adenoidectomy as far as possible and under vision. I'm very sure if those children, we have also done blind, adenoidectomies during our residency days. And if we would have followed up those patients, definitely there would have been recurrences and relapses. I'm very sure about it.
Yes, Sandeep, well said.
Thank you. If the panelists don't have any other comments, is Deepak around? You want to say something, Deepak?
So interesting discussion going on about adenoidectomy. My thought is, whatever you do, you need to go with a process to say, this is why I'm doing this. There's no point worrying about a little bit of recurrence. The usual recurrence happens is because of untreated allergies. Okay, and what if someone comes back and has a little bit of adenoid tissue? Your aim, like Dr. Shaikh said, your aim is to make it less obstructive or take the obstruction off. There's no point going laterally, because if you go, you end up causing a nasopharyngeal stenosis. If you're overdoing it, again, you need to be careful, because it might be experts who are doing it really well, but you're talking to a bigger audience. Some of them are learners. You don't want to be too aggressive. You need to be controlled, because what's the worst thing can happen? There might be a little bit of regrowth. You can always tackle it later. Usually the regrowth is more common in younger kids. If you are doing there's a paper out there, if you have done adenoidectomy under 1, they'll grow back, and they are for various factors. It's not just your surgery. It's for various factors they can grow back. So that's why it's better to be less aggressive. It's okay to leave a little bit of adenoid tissue somewhere. Your aim should be to unobstruct the airway. That would be my thought.
Thank you, Deepak. Is Shashi in the audience? Shashi? Shashi there?
I cannot find him.
He's run away. He usually is a person who is current with all the journals latest. I thought we'll share something from him. Ajoy is there? Rakesh?
Rakesh is just left.
Joy is there. Joy is there.
Ajoy, any comments from you? Please unmute Ajoy so that.
Yeah.
I am unmuting Ajay.
Yeah. Thanks, Ajay, for joining.
Yeah, there were excellent talks. Yeah, hi. There were really excellent talks. I mean, not much to comment about. The only thing is, I think with the advances or with most people having mobile phones, I think taking a, sleep video at home makes a lot of difference. Because children, when they sleep better in their own environment. So sometimes it's a good idea to ask the parents to take a video while they're sleeping at home, which give a lot of information.
Yes.
Thank you, Ajay. Anybody else in the audience? Dr. Bilagi is there, or who else? Rakesh and Sashi both are not there. We would have loved. Dr. Gnanam, your modified sleep, this thing was praised. You want to say something about it? How you evolved it? Okay, I think she's also not there. Anybody else in the audience? Just show of hands in the chat box. We can ask you to speak directly. The chat box, my friends who participated today, I mean, it's full of compliments. Thank you very much for this wonderful audience that I think we should thank Prahlad for that. And of course, we need to thank the panelists and the speakers. They were wonderful. We had a thought process in mind as to what to achieve. I think if I had to rate myself, and I'm usually very lenient with myself, very strict with myself. So I think we've achieved more than 10 out of 10. We've gone beyond that. And for that, I need to thank Seemab and Srinivas. Deepak, thank you so much for joining in. The panelists, Dr. Bansal, Sowmya, for adding real value to the whole thing. And thank you so much. I think we'll call it a day. Any comments from Prahlad? Prahlad?
Sir, thank you very much. Really honored to have you all here on this program. I have a request. Can I post on the YouTube this presentation with all?
Yeah, we have the permission of all the panelists and the speakers to put this on YouTube.
Yeah.
Show of hands. Yeah, and then next week we are on recurrent respiratory papillomatosis, and we promise you a good, enjoyable session. Please stay hooked to us.
That should be good.
Thank you.
They are raising hand a little.
Is that all right?
Yes. Thank you all.
Thank you.
Thank you all. Good night.
Thank you.
Thank you.
Good night.
Okay. Yeah.
Night.